Good to see you. So before we get started again, the CME codes for today are going to be 15243, 152, 43, and 15242 for the Seagulls for the Florida group ahead that are just probably going to be joining us any second now. All right, so 15243. So Sandy, you went off to Zion. I said Mount Zion, but Zion National. And how was it? Was it fantastic as I remember it?
Oh, it was absolutely fantastic. We went to Zion, we went to Bryce, but most importantly, we went to Antelope Canyon. And if you haven't seen Antelope Canyon, it is absolutely spectacular.
Okay.
So I highly recommend everybody put that on their bucket list.
Yeah, I have not done that, so that sounds like a good plan. So, all right, well, I'll make sure that's done. Okay, sounds good. Hey, so anything? Well, I got you on. I'll take a report for you, then I'll go over to Jim Augustine. Anything you had reported on from the American College of Emergency Physicians? For those who don't know, that's right. I should announce that this is all recorded out there for posterity. Although it's our private meeting, the world wants to listen in, so keep that in mind. So our gathering of the jurisdictional medical directors of most of the largest cities in the United States, plus their counterparts and in other places, as well as our friends and neighbors from the American College of Emergency Physicians, like Sandy, who's our executive vice president or executive associate director there, and senior vice president, blah, blah, whatever it is, right? Whatever it is today, right? So it's good. Like she's the top dog. Okay. So that got us under the, under the executive director in terms of the medical care and clinical affairs. But anyways, so we'll get a report from the American College of Emergency Physicians, and we also have various other people from other organizations over the years. So, and companies that are just very smart people. We love having you on the phones with us today. So let's go with Sandy first. Sandy, what's going on?
Yeah, so that was the longest title I think I've ever had in my life. The more you stumbled over it, the better it got. But anyhow, thank you, Paul.
You are the senior vice president of the college.
Yes. So a few things.
Know, just what does the title senior mean? Does that have something to do with your age, or how does that work?
Yeah. It definitely is, but has to do with my age. And since we're not that far apart, you know exactly how bad it is.
Yeah, exactly. Right. Okay, that's why when they put me on as a senior author, it has different meaning, right? So, all right, go ahead.
Yeah, so things are getting back to what I will call normal, the new normal at ACEP, and we're working on a variety of topics in addition to COVID. In addition, our CDC grant is winding down. Want to mention just a few things. The contrast, I'm interested to see if there's still a contrast shortage. I know it was very, very severe before I went on vacation. I don't know whether people have just adapted, but if you could just put in the chat whether you're still having a problem with contrast and are still limiting the number of studies. We're also continuing to see some sporadic children that are infants that are being fed watered down formula. So the formula shortage continues. Just a couple of our members have written and said they saw children with very severe outcomes from water intoxication. The other two things that we're continuing to work on is the epidemic of opioids. Not sure we're going to find an answer to that. And mental health, I'm absolutely sure we're not going to find an answer to that. And then, like everyone, we were obviously very shocked and very upset about the shootings just across the state from me here in Texas. I think that's just, it's become such a normal, abnormal thing. I don't have words.
Yeah, it's kind of interesting, and hopefully you could stay on, I did get a request from both Chris Colwell, who's not on yet, and Peter to make some comments, their own op-eds. So we never tend to give opinions here at Eagles. We just, out there are the data collectors, we're the people out there, boots on the ground, finding out information and so on. But it's still, as individuals, I'd like to see their reactions, and they asked me to talk to you guys because we're all friends, and I think that's an important support system. Chris, I know, was at Columbine, and Peter, of course, at Parkland, and so I think that's probably the reasons why they would like to mention. I think several others of us have been inside some nastiness as well. So,
Paul, if I could just interrupt, we did have a peer-to-peer session, just an open session last Friday for docs to talk. I mean,
Yeah.
I think we and the other healthcare workers are sort of the forgotten group that gets impacted by this. I get it. I mean, I'm not saying that we're like the worst, but there is a definite impact on healthcare workers that have been at scenes like that, and we often don't talk about it. So we did hold a session just for people to vent to one another last Friday.
Yeah. Okay. So, hey, John, Jew, how are you doing on time? Because I got to make sure you have an important role today, I think. So,
Yeah, I'm good, Paul. Thanks.
okay, good. And then also, I'll wait till Eileen gets in so you guys can comment on that last JAMA paper, et cetera. And then let's see what else. There was someone else I wanted to get on. Okay. And then is it Sun Hee from your organization? She was supposed to maybe try to get on, and I just want to let you know I may have her talk about the intraosseous, just so you're aware of that, John. You know that you aren't blindsided. Right? Okay. So.
Yep.
All right, so let's talk to a couple of people that have to get off pretty soon. Jim doesn't have a whole lot to report, but still always great to have you on. And tell us, though, what you did do about a week ago in the city of Chantilly, Virginia, okay?
In beautiful Chantilly, we discussed the future of EMS and the needs assessment for the U.S. Fire Administration. So the U.S. Fire Administration, aware of the all hazards nature of fire EMS services in the country, pulled together a group of leaders to talk about the needs. And you all are aware it starts with people, and then with educational processes, and then with the equipment and facilities and processes that we use to get through our day. The second important part of the USFA move forward is to have an update on the EMS Medical Director's Handbook. And so several Eagles were part of that. Paul, thank you very much for your contributions and some prior Eagles documents that got shared at that meeting that will serve for the next 10 years, once published, as a blueprint for how to have medical directors serve their systems well. In particular, the fire...
Yeah, can I interrupt you for a second? I wanted to make the point that, what we said, oh, well, at NAMSP, we've got the medical director's course, and we have the textbooks we did when people get their board certification and so on. But first of all, there are many medical directors out there for services that don't have access or are not members or don't even know where to start. They're from other specialty areas sometimes. And it's clear that there are people that are still out there that need that help and support. Plus, this handbook is more, I think, operational in nature, not clinical in nature, which the at AMSP textbooks are. You want to comment on that and see if that's going to be okay?
Yeah, very good. So this really is intended for the example they gave was an ophthalmologist who was asked in a rural community to serve as a medical director. What could they serve as a resource? That individual doesn't have the time to do full board preparation and to attend a week of conference, and gets paid nothing and is doing a great service. So this is dedicated to individuals along those lines, as well as the Glanacedas of the world, and all of you who serve and have moved up through, like Dave Purse and Libby Char and others, to serve at very high levels. So we're going to break up the dedication of this to low resource and, if you will, part-time medical directors through to big resource leading EMS systems with very experienced medical directors.
I want to put a big shout out to Dave Miramanis, who contributed as usual very significantly, and also to Megan Marino, who was very, very helpful as well there. So, and then there was some Jim Augustine guy. He always seemed to be always have the most sage and smart thing to say, but whatever. So.
Not. No. We got to see IFC, and then an important announcement last week while we were there. Actually, the IAFF has appointed their first chief medical officer, who is Dr. Danny Wu, an MD, MPH, will be the first chief medical officer for the International Association of Firefighters. He's had a long career with Miami-Dade, was a firefighter paramedic with them, and then moved up through the system. And at some point, it's not exact, he went to medical school, and continues to serve. So Dr. Danny Wu, new Chief Medical Officer for the IAFF. Our major discussions today: onset of wildland season, our first tropical storm likely to form in the Gulf in what is likely to be a busy year. Drug shortages and people shortages are a very significant concern amongst the fire chiefs. And number 4 is that our COVID task force, which has been in place for about 2.5 years now, will convert to a more general medical preparedness task force. And we'll talk about monkeypox or other variants that come our way. Those are the big news items, Paul. Thank you. And thank you for your leadership that allowed us to move forward in groups like the IFC. Thank you, Paul.
Okay. Well, let's see. Next, I guess I better get through some of the people that have to get off soon. Got you. Dave Purse. Well, first of all, I think Mark Gautreaux, you've got to be off pretty soon yourself over there, right, in San Jose. So anything new to report or anything we need to know about for you before you move on to others?
Not much, COVID, schmovid, same old thing. Still seeing a smattering of cases here and there, but very little in the way of hospitalizations. But no, what we're really focusing on right now is reinforcing our high performance CPR training, which is what I'll be doing for the rest of the morning.
Okay. And then later, one of our talks we're going to do is that high performance CPR includes high performance ventilation as well, quality ventilation. So that'll be one of our talks at Eagles this year. So it'll be kind of cool. Thanks for bringing that up because it sparked me thinking about that. It'll be one of the things we'll have to add to what constitutes quality CPR. But the stuff you're doing with the high performance is fantastic. And by the way, you guys have done such a fantastic job in terms of getting your folks vaccinated. What was the final count in terms of the number of people that had at least 2 vaccinations? Do you know?
I think last I heard, we still had on the sworn side, I think about 3 members who are still holding off.
How much? How many?
3 out of
3?
the 650 or 700.
Wow, impressive. Good for you then. That's really great. That's probably another reason why you're doing so well there. But it's interesting. I'm seeing more people, even though they've had 3 shots or 4 shots even or whatever, getting COVID within the last month. A lot of my friends, it's usually mild cases, but it's extraordinary about how they finally, after 2 years, they said, I finally got COVID after, trying to be as careful as possible before. And so
we had a huge outbreak on our faculty, our emergency medicine faculty from SAEM.
Yes. Yeah. Right.
So those of us who didn't go to SAEM have been working a whole bunch of extra shifts.
To cover for them. Yeah. We kind of mentioned that last couple of weeks ago when we saw it because it looked like it was a super spreader event. So you saw the same thing. That's interesting. Yeah. Okay. Well, good. Well, I don't know about good, but I'm just still very happy about what you guys showed there in terms of getting your people vaccinated and protecting them. The force protection is a big deal to us. All right, next on the list, David Purse. Let me go to you because you have to get off in about 20 minutes or so.
Yeah, good morning, Paul. Good morning, everyone. So nothing really huge to report here in Houston. Our wastewater has gone up. It went up about a pretty big jump this last week, went up 40% in 1 week. And our positivity rate is now almost 15%. Of course, I don't know how much to put into that because so much home testing, but that's gone up. Our hospitalizations, they're going up from a real low level, really a little bit like everybody else is seeing. So the wastewater, it's taken off, but not yet in hospitalizations, and our deaths actually are very, very low. So.
Yeah. So I think it's kind of my gut is that people, even those who hadn't gotten it before, are getting exposed now, and they're getting it. Unfortunately, they've been vaccinated or we've developed some degree of immunity as a population. So I hope that's the case. And so maybe it's true, the true herd immunity we're hoping for, it's going to happen here. So, but I'm still concerned about, I'm hearing skyrocketing influenza cases in many areas around the country, and, and the other things we talked about before, like adenoviruses. How are you seeing flu there, since you're the health director?
So we just got a report this morning, and here in Houston, we had like a double hump curve of flu activity, and we are, it's going down pretty consistently now for the past several weeks. But yeah, we had a spike in the fall, and then that dropped off, ironically, right around the holidays, when it's usually when we get a spike, and then it picked up again in February and has started dropping down again.
Okay, got it. And then, David, you'll be coming down to Florida as well, right?
Yep. So yep, I'll be there. And then the one thing with COVID is that what we don't have a good handle on, maybe some of the other folks are, is I do worry about the long COVID because we're getting a lot more people who are
Right.
previously vaccinated. They're getting sick, but they're not getting hospitalized. Yet this long COVID thing is probably flying under the radar, and that could have a major impact. And
And I
don't
think
really
it's
have great
probably-
measures about that.
in my gut about this, it's very much a spectrum. So some people don't even know they have long COVID, except they just don't have the same energy they had before. They have a little bit more brain fog, but maybe they think I'm just getting older or whatever it may be. I think there's probably subtle levels of it versus the ones that are these really hot cases where they have the kind of the chronic inflammatory syndromes that that are really terrible and debilitating, so on. And then there's so the good news is we're not seeing the people with the permanent loss of taste and smell that many people have had. I've had some personal friends who are chefs, and it's just been destructive for their life, that kind of thing. Then they had that. Anything else? Then everybody else doing well there in Houston? Otherwise, so
Not a single problem in the city of Houston, sir.
yeah, okay, got it. How about Houston doesn't have a problem, right? So, hey, how about Chris going to be able to come, you think, or is he still going to probably not be able to make it and cover for you?
No, Chris is not going to be able to join us this year.
Yeah, so he'll be covering for you there. Okay, thank you though. Thank him for that. Okay, so I really appreciate that. All right, good. So let's then move on over to see who else had to get off here. Ray, anything to report from Dallas rather? Ray Fowler.
Yeah, the numbers, we are close to 2% overall in North Texas for our overall COVID census in the hospitals, and the ICU census remains about 1%. Interestingly, pediatric inpatient census lingering around 2%. So things keep going. It was interesting this morning, a report that I saw that the COVID level of patients across the country right now exceeds the summertime flat line that was there. So it definitely seems to be on a gradual uptick. What's going to happen with inpatients, we don't know. What's going to be the impact of Paxlovid, we don't know. But vaccination is still key.
Okay, got it. Well, it's good to see you as well. And so I hope you stay well as well. And we're going to see. And then I heard that you and Terry Valenzuela are going to give one of your classic debates on Thursday afternoon, if I remember right.
Yeah, I'm going to beat the crap out of him.
Okay, sounds good. All righty. Well, let's see. The next person I wanted to mention, you can see it time-wise, I think we got everybody covered. While we're at it, you just posted something about the DEA there, Angus. Angus is our state medical director of Florida and also covers our region there in Tampa Bay. So what do you what's going on there, and what do you think's happening? I'll have Mike Levy comment on it as well.
Yeah, the Protecting Patient Access to Emergency Medications bill that NAEMSP was successful in getting through back in 2017 is still stuck in DEA rulemaking, and so has not sort of fully been implemented. And it's something I've been watching close because we're making some improvements to our controlled substance handling here locally. But I was a bit surprised.
What were some of the issues, like the one or two bullet issues, and what were the resolutions you guys were trying to make about that?
So for us, we're just trying to improve tracking and security and handling and record keeping, et cetera. We're moving to an electronic system from old paper logbooks. But we're just trying to make sure that we don't do anything different from what the rules will be here shortly when they're promulgated from the DEA. This particular issue, though, I was just surprised to see the American Psychiatric Association weigh in during DEA rulemaking related to controlled substances and EMS, specifically around ketamine once again.
Okay, well, then maybe we need to be getting into their business and help out with rulemaking regarding mental health issues, I think, right? So, yeah, that's interesting that they're weighing in on our issues there in our practice. So that's an interesting thing. They're still at it. So I hope that does go away. Mike, what's your commentary about that? Mike Levy is our president of the National Association of EMS Physicians, let alone the medical director for Anchorage and the state of Alaska.
Hey there. Well, I appreciate Angus bringing it up. We were just talking about rulemaking progress in the board of directors meeting a couple of days ago that we had here on Anchorage, the NAEMSP board meeting. It sort of fascinates me. Again, I guess I'm just too naive about how politics work, honestly, but the rulemaking was supposed to be done 2 years ago, 18 months ago. 1 year ago. It was posted as such, that it was due on this date. I think the last one I saw was June of last year. Anyway, they don't have to turn their homework assignments in on time, it turns out. We're hearing that our H&K says it looks like maybe the fall that the rulemaking will actually be done, but they keep it pretty close to the vest.
What's H&K? I'm sorry.
Oh, it's our lobbyist
Okay.
group
Yeah.
that we
Okay.
ANSP uses.
Okay.
This is a huge issue. I mean, if they snuck this in on us, it would be a big problem for us. Whether we can act proactively on this or not with regard to DEA, I think is very unlikely. Again, DEA is law enforcement. They really are not looking for input from us at this point in time. And it's been quite clear there was an opportunity during public comment, and we took that opportunity. But at this point in time, if something like this happens, it'll be something we'll have to respond to when it happens, I guess, as opposed to trying to be proactive at this point in time. It's certainly a concern. And as you're singling out people who've left their lane, I wouldn't ignore the anesthesiologists who remain blissfully ignorant about the use of ketamine.
Yeah. Okay. Well, maybe we should get in there and help them out with how they manage cardiac arrests that occur in the operating room, right? So
I think just inviting them for some evening ride-alongs in the big city would be good. Letting them kind of be at the sharp tip of the spear would be helpful for us to have their expertise there.
would that work out in New York City, Glenn? Because you guys never get any problems with people who are very difficult to manage, right?
No, never. Everybody.
How many a day would you think you guys run into? About 20, 30 more?
Oh, yeah. That's probably a good number. Yep.
Yeah, that's right. Certainly. So, all right. Anything else though, Mike? Before I'll talk to Glenn while he's on. But anything else, Mike, from your end?
No, I can speak to NSP later before I go off the call, or we can talk about it later. Thanks.
Okay, got it. Hey, so Glenn, anything to report from your end, by the way?
Yeah, our hospitalizations last week went up above 10%. So City DOH raised our COVID level from medium to high. That didn't really change anything. Masks are still recommended. Public transportation, they're required, but we're finding very, very few people actually wearing masks. Our call volumes have gotten back up really to what we normally would expect. We had a heat wave, not quite a wave yet, but our temperatures went up and our call volume went up as high as 4,800 over the weekend. Today it's supposed to hit 94 degrees in the city, so our volumes are already going up. We're watching that, and with heat comes more violence, unfortunately. So we expect more unfortunate shootings and things, I think, as the summer starts.
I heard the best way to deal with the heat is drinking a lot more cold beer, right? So
Absolutely.
All right. Well, thank you very much. Good to see you, by the way. And hope
Thank
everyone else is doing well there. And I'm looking forward to seeing it. Did we get everything by the bureaucrats, by the way?
Yes, thank you. Yes.
All right, got it. Okay, good. Thanks a lot. Hey, Candace, I guess speaking of the meeting, well, I guess if you can be on and talk to us, let us know a little bit of some of the issues we're dealing with, or what do you want to talk about with the group? Are you there, Candace? Okay, Candace was on. She's probably busy doing everything else like she is. She's always multitasking, etc. So let's do this. Let's see, Peter, are you on? And I'm trying to see if Chris is on yet. Chris Colwell. I'll see if I can text him and get him on, and we can go into that particular issue that we wanted to talk about. Candace, are you there? If not, well, we do have Ted Newton.
I'm here. Sorry about that.
Oh, yeah. Okay, good. Let's do that. So is there any things we should talk to the group about, or you want to ask them to have or get for us or need from us or whatever, or pay attention from us in preparation for the meeting, which is only like 2 weeks away, right? So.
Yes, we are T-minus 14 days from today. So thank you everyone who submitted their registration, their hotels. If you guys have any questions about that, please reach out to me. For those who did the link that was sent out as part of the registration, Johanna, who's our conference coordinator, will be sending you your hotel confirmation. So if you get stuck or need any of that, please reach out to me. For the conference, you will also be automatically registered for the Eagles main conference, and we'll be sending out kind of a social agenda and things to do throughout the week. As a reminder, Monday, there's an opportunity for a cadaver lab. Tuesday, Wednesday is Eagles Creek at La Meridian. Thursday, Friday is Eagles Main at the Hard Rock, and we will provide transportation to and from. There is a gala Wednesday night as kind of an opening to Eagles conference and closing of First There, First Care conference. And Thursday, there's a medical cadaver lab available as well. So I'll send this out to everyone as a reminder. If you have not done so in the past, send me your CVs. I have most everybody, and you're going to get a love note from me if you haven't completed your disclosure on the Cloud CME app. So those are the last two things pending, is your disclosure updates and CVs if you haven't sent me one recently.
Yeah, and I think that hopefully everybody got topics into Meg Marino's collating those for me. And also I need to have, she's going to send out a thing with your titles on it from last year. I want you to update them in case anybody was promoted. I just heard that Sophia Dio, for example, was promoted from, to a professor, full professor. And I want to, if you had those kind of promotions or change your title, or if you're no longer the medical director and you have someone else new in your place, I need to make sure all that is updated. So when I put the brochure together in the next week or so, we'll have it all set to go. So I just will, please pay attention to that because we got to turn this around quickly, if you don't mind. Okay, let's see, Candace, anything else? And then for the obviously the core Eagles will be doing a dinner on Tuesday night and Thursday night. That's kind of required, so keep that in mind. And then also some of us are talking about just gathering somewhere long Monday night as people arrive early enough that we'll try to go to a place nearby, sort of informally. But I'll talk to you more about that as the time comes up. Okay.
For
And
those staying at La Meridian, there's a shuttle to and from the airport. There's kind of an executive lounge and a couple of nice bars within the lobby and at the hotel. So it's a lot of nice places to meet. And essentially this group has the whole hotel. So we hope you'll find that time to be able to meet. It's a little bit more comfortable and a lot easier to convene.
in fact, Candace and I have met there a couple times in the last 2 weeks, and it's really great meeting place and really well located. Now, how do they find the shuttle? Do you happen to know? I have to go physically check that out, I guess.
I can send it I can send the information to everybody to remind them. It's on the hotel website and there's a number to call. They'll pick you up.
Okay, cool. That's good. That would be fantastic then. So that'll be an easy shuttle because it's only like literally 8-9 minutes away, even with the traffic at the airport where people are loading and unloading. So it's pretty convenient to the airport. So, okay, great. Let's see, anything else you can think of? So if not, let's just,
Any questions for me?
no,
Please
but
make sure for those of you who haven't been claiming CME, that Cloud CME app, I will remind everybody about it again. You need to download it because that's how you'll claim all your CME for the conference, for all sessions, for paramedics as well as physicians. So anybody that has a license and you're going to claim any education, it all has to go through our Cloud CME app. All your evaluations will be there. Everything you need will be on that app.
and the other thing is speakers, we have to have disclosure. So through that same app, you can update your disclosure. I have none, whatever, none, or I have this, and this now, right? So because we need all those things. Speaking of which, Nick Miller, are you on? How are we doing on that? And we gathering the information for you? Is Nick there, Josh?
I'm not sure, but I can certainly speak to it.
Yeah,
We're
go
meeting
ahead.
today. We've had multiple conversations with the group. We're meeting again with Candace today to go through some final details on the CE component for First There, First Care. Already confirmed CAPC accreditation, so that's done. So yeah, we're on our way.
Okay, good. So yeah, I wanted to give a shout out to Josh and his team for providing the CAPC. So we have a national, what do you call it, CE certifications for the paramedics and the providers beyond our own medical CME that we're getting there. So thank you for providing that, doing all the work to put that together, and appreciate it. It's not unnoticed. Okay. Anything else I got you on? Anything else you want to ask or talk about or see? So we'll see you there. Yeah.
No,
Okay.
again, just great listening to you guys, and hope to see several of you in a couple of weeks.
All right. Very, very good. Okay, good. Hey, I just was thinking, I saw Ted Newton there. Ted's always been one of our greatest supporters in the Eagles and in general, in terms of his organization over there with Phillips. And you're going to be there as well. Correct, Ted? Is that right? So I saw.
I wouldn't miss it.
Yeah,
Yes,
people-
sir.
I wanted to put you on mostly because if people see you running around the hotel, I'll be telling people you're some kind of celebrity, that kind of thing, and they may want to get a photo op with you. That's also.
I'll be limping around, but luckily for me, I'm out of my cast and out of my walking boots. So if you see somebody stumbling along, that's me. Please come up and say hi.
So
No,
if you-
Dr. Pepe, we're super excited about 2 weeks from now. This is the biggest show of the year for us. Not, not in size and stuff, but the one we really target and the one we, allocate a lot of money and a lot of resources to. So have a big group showing up, have some people coming from the United Kingdom that are working on some projects that I would love to, bend some people on this call's ears about, and we'll talk about it. We'll introduce it at Eagles Creek like we do. And just excited to be down there with you all.
And then, and I have to say, I wasn't as sensitive to making sure that we got our people out to not only see your exhibits, but also the other vendors. And so we all here have a commitment to just be more sensitive to that and get out there and help, or even send our folks over to see what you're doing, especially after we've seen something at Eagle Creek, if we think it's appropriate. But of course, but the point is that we know this doesn't happen without you. So thank you so much. Okay. So really appreciate it.
Yeah, you're so very welcome. And last year was such a crazy time. And I just applaud you all for getting the show and putting it back together and getting it, kind of starting that ball rolling. So we, as I mentioned, just one little commercial, and it's not about products. It's really about what you all do every day, which is try to optimize your patient care. We will talk to you a little bit on, I believe it's Wednesday. We're still waiting on exact timings, Dr. Pepe, on that. But just something that we're doing that's really concentrating on faster throughput and on staff retention and morale and different things like that that we're working on. And again, we'll talk about it on Wednesday with you.
Okay, good. I just want everybody to get to know who you are, and if they see you, floating around, they know who it is and how much you mean to us. So, as the organization, actually, I should call it an organization. This kind of like whatever. The sort of rat pack of folks kind of got together, and we've had this annual meeting thanks originally to the forerunner, so to speak, right? Heartstream, et cetera, that you guys adopted. So you guys have been with us from day one. Thanks to Ray Fowler, though. We always have to give Ray Fowler credit for making sure that everybody was drinking well at the first meeting, so that there was a commitment to cover this meeting every year, right, Ray?
It is a solemn duty that I assumed 20 years ago.
The point of the story is that this is before Phelps, of course, took over, but the Heartstream representative did take us out to dinner that night, and I thought we were showing up late because I had the West Coasters giving the last lectures, and because of the time change, and you guys, I thought we got there at 10:30, and I thought we were in trouble. And the door was locked, and eventually it opened up and we were allowed in, and we ran upstairs, and they hadn't even gotten to the salads, I don't think, yet. And because Ray was ordering wines for everyone, and the representative from the company leaned over and said, "This is the greatest bunch of people I've ever met. We're going to run this for you every year." So thanks to Ray Fowler, here we are.
That's called liquid persuasion, Paul.
Well, anyway, it's just always an important part of history. We need this time in history. So it's great. Well, thank you all. And Ted, anything else? Ted, would it be a what do you call it? What's that called? A HIPAA violation if you let us know what happened to you?
I thought I shared this before, and making it go through it, I can't. It's playing pickleball. All
yeah,
right?
Exactly. So just
tib fib. Yeah, tib fib.
Yeah, so keep that in mind for those of you who are venturing off into the pickleball world, right? So that's it. All right. So
thank you very much, and a huge appreciation to Candace, who's been fantastic coordinating all of this.
She's amazing. Yeah, I know. This would not happen without her. She's fantastic. So it's good. All righty. So let's move on to a question I have. I was trying to see if David Miramontes was on, but he hasn't gotten on, because I was going to launch into this issue of talk about intraosseous. But before we do that, can you hang in there, Sanhee, for a little while longer?
Absolutely.
Okay,
Yes.
good. All right, let's go to John and Eileen on the ID land before we lose some of our other folks who are interested in this. And is there anything discussed, John? There was a new publication that came out recently about reinfections, I believe. Can you tell us a little bit about that?
Yeah, I think the CDC just came out with a bulletin about 2 or 3 days ago, looking at Paxlovid and the breakthrough after you're stopping the Paxlovid. In fact, one of the ID docs, I think in Pennsylvania, basically took Paxlovid and he was repositive and had symptoms after that. So while I think Paxlovid is effective, we just need to keep in mind that the Paxlovid is not panacea. It probably prevents serious infection, but not, I would say, symptomatic infection here as well.
Do they put it back on it again if they had a breakthrough, just like?
No, I think just gonna, Eileen might want to comment on that, but there's no data on putting him back on. But it's an antiretroviral, and this is somewhat to be expected here as well. I've had 3 ED patients actually with those kinds of symptoms as well, but they are all, I would say, non-acute, non-hospitalized as well.
Okay. You want to comment on that one before we go to the other issue, Eileen?
Well, one of the fun things about having a COVID lab where I can see the CT values is, I can put a patient on Paxlovid and then watch what happens. And what I've seen is, within a day of giving them the Paxlovid, the CT values just, you have the number's very high, which means your viral load becomes very, very low. But after they go off of it, invariably the viral load goes back up. So the CT values go down. And several of the patients that I've had on Paxlovid that I've been able to follow because they've been kind enough to get retested on a frequent enough basis, the amount of time that they're positive for virus has averaged about 20 days.
Okay.
And in those 20 days, some days they're below 30 CTs, and most days they're above it. And I point that out because 30 and below is considered significantly infectious. 30 and then above 30, not so much, not so infectious.
Yeah. So it's interesting. Again, always in my realm, it's generally anecdotal, but I interact with so many people that it kind of goes sometimes beyond the world of anecdote. Is that I'm seeing a lot of people who have gotten ill. They test, they're negative, they test, they're still negative, and then all of a sudden, boom, 4 or 5 days later, suddenly they're positive on antigen test or whatever they're testing themselves with, and they remain that way, and then they get better sometimes, and then they may even test positive again. So I'm seeing it. So I don't know if it's a problem with the test, or is it or is it just the fact that there's the differences in the virus and how it reacts, et cetera. Do you know what I'm talking about? And have you seen the same thing? And what's your explanation, since you're our guru on that?
Well, first of all, absolutely, I've seen it, and I've seen it with a bunch of people now personally. And of course, there are several reports on these things as well. But the bottom line is, what I think is going on is we do have a certain amount of immunity in our population from exposure or vaccine or both. And as the paper you sent out this morning, you and Peter from JAMA, addresses the fact that people who have immunity, and in the paper they were talking about vaccine immunity, they're able to kill the virus a lot more effectively. So we may be getting these negative values because they are managing the virus to a level that the test doesn't show up positive.
Yeah. So keep that, and that's kind of important for us to be, because let's say you had someone who got sick and you tested for COVID in your organization. It may not mean that they're not, COVID positive themselves and all that. And we talked about this before, because I remember when I was feeling ill and I tested it for like 9 or 10 days, and also did a PCR, et cetera. So it wasn't there, but there are so many people I know that were negative for 4 or 5 days, and then all of a sudden, boom, or 3 days, and boom, they're positive. So they're, in retrospect, they did have COVID. So, or let me ask you this: are they getting sick with something else? That was the next question I was going to have, and then they just happen to also get COVID too, because they're out, exposed or whatever. So, you think there's a combination of those, or do you think it's more the way the COVID's reacting nowadays, because it's moving through our population, as David Pearce just showed us with the the wastewater stuff going up. And-
Yeah, I think it's just the COVID. I don't think it's because of secondary infections, although you can't rule that out for a given individual.
So tell us a little bit about the article on the shedding kinetics for vaccine versus non-vaccine. You alluded to it just now, but can you just give us a little bit more specific thing they found in it, and if you think it's a good study or not, or
Well, I mean, it's a cohort study, and that makes it worthwhile. And it's not a very large study. They have 173 total individuals in their study. But I think it's a valid study that's providing a useful conclusion. Their conclusion is that the initial genomic viral load was similar between the vaccinated and the unvaccinated, but that the vaccinated people basically did better. So I think that this is good information and makes sense. It makes sense from what we know of biology and what we know of how this virus and other infections have happened in the past.
Yeah.
How they've affected populations. It's a very reasonable report.
Yeah.
John?
Well,
go ahead.
there is a previous study, Kistler et al., that was published in New England Journal of Medicine in December. I have one screenshot that may be helpful for the people here as well. And let me know when you can see it.
It's coming up. There you
There
go.
you go. Yep, we see
Yeah,
it. Oh,
so-
you showed this before, John.
Yeah, it is. So, but basically, the Korean study replicated Kistler's study, where I would say there are two comments on it. First one was that it was done during Delta. The second one, it basically confirmed Kistler's study. What you can see, it's a little bit very fast, is on the, I'm not sure if you can see, can you see my pointer right now on the screen?
Your pointer. I'm
Yeah.
Nope. I
Okay,
don't see a
so,
pointer.
okay, so
But you can
look at,
use, John, you can use the annotation like this.
yeah, that's okay. I'll just point out to the middle of the right vaccinated versus unvaccinated, the middle of the left green versus purple. You'll notice that the vaccinated individuals had a lower, I would say, duration of viremia. On the bottom of the one, the vaccinated versus the unvaccinated, in the left-hand lower corner, you notice the peak viral load and what we call Alpha, Delta, and basically Omicron are the same. But if you look at the clearance time, the vaccinated individuals had a shorter clearance time. So we can learn two things from it. Number one, that the vaccinated individuals, no matter what strain it is, cleared the virus faster. And number two, they had a same viral load initially as well. So we think, for obvious reasons, that the vaccinated individuals are doing better here as well.
Yeah. So so all this is kind of intuitive in a way, but it's great to have some numbers to back it up, what we're saying. But my takeaway from everything we're saying today is, even if you have vaccinated people, or maybe even particularly if you have vaccinated people, is that if they get ill, be suspicious, that kind of thing, especially if they got a minor cough or whatever. And even if they tested negative, still be wary, especially early on in the disease process. That's my take on what I've been seeing over the last little while. Would you guys disagree with that, John? Would you disagree, because you're responsible for a group of people?
Yeah, I would agree with that. In other words, I think what we're seeing is the vaccinated people, especially that have boosted and double boosted, they have a much shorter period of time. And frankly, they have and this is anecdotal, much less severe symptoms as well. And I actually think, I don't know what Aileen thinks, but I think the chances of long COVID is less in the vaccinated people as well. But I have no data.
The data is a little confusing on it, John, but and they're showing like a 15% reduction, and that's it. But I don't believe it. I think it's much better than that. I think it's probably going to prove to be very significant if you're vaccinated and boosted in terms of reducing your risk for long COVID.
Yeah, but we had about 4 faculty members attend SAME that were super spreader. They were positive here as well. So,
so an interesting thing is that you may get long COVID before you got vaccinated. The people who got vaccinated didn't. There are anecdotes where some people might have cleared up after the vaccine, but for the most part, the cases that we were studying here in Florida they didn't get better until they had the other treatment, which is kind of interesting. So the issue is make sure you get vaccinated first to prevent yourself from getting long COVID. All right, so there, at least we kind of believe that that's our inclination here, and that's why I'm always carrying this around with me, no matter if I go into a CVS or whatever. And then I was at a fire station the other day, and we'll be very blunt, one of the guys there was just coughing away, and hardly anybody noticed it. I'm sitting there going, okay, so I'm sure that there was something anyways going on that could have been contagious, right? So keep that in mind out there, and we're still advising people to stay as masked whenever possible, etc. So because there's other things going around as well. All right, so let's see who I wanted to go to next. There was a couple of people. Well, before I move on, let's from the infectious disease areas, let's talk to the health director from Hawaii and see what's happening out there. Can you tell us anything? Are you getting more let's say tourists coming in, bringing in diseases, right? So, or bring them back from Las Vegas, as you told us last time, right? Right, Libby?
Yeah, good morning, everybody. We are just going gangbusters on tourism. I think people want so badly to travel. We're getting well over 30,000 arrivals a day.
Wow.
So it's really taking its toll. And ironically, our numbers are just super high right now. We're seeing over, I think it works out to about 70 plus per 100,000 cases. So we are way, way high right now. Thankfully, it's not translating to hospitalizations so much or deaths like everybody else. But what we're trying to figure out is how do we sustain testing? We don't have federal money for that anymore. How do we keep the testing going? Who's going to pay for it? And how do we make sure that access is there? So curious to know if anybody else has any insight on that or what everybody else is doing.
So Libby, I think the government was going to require the insurance companies to test. Does that make sense? That's what I'm hearing as well. Then we need to cover the uninsured population here as well.
Yeah, they've been real obstinate though. They're saying they'll test if it's a diagnostic test, but they won't pay for surveillance. They won't pay if you need it for work. They won't pay if you're asymptomatic. So it's been a real pain in the butt. But as a result, I think less people are testing, and we know it's out there. So kind of creates a little bit of a dilemma.
Yeah. So anyways, how's it, well, is the federal government being mean to you because they're suing you, or?
Yeah, they finally took that lawsuit away, and the Navy agreed to defuel the hundreds of millions of gallons of jet fuel that sits over our aquifer that has been getting into our drinking water. So
yeah, okay, got it. All right, well, thanks for the report. And then let's talk to anything else that you can tell us about. EMS is transitioning to the city. Honolulu is going to have their going to be independent of the state system, right? And when does that take place?
So they'll have some autonomy, but it's still a statewide system. It's just that they will be financing it differently, and so that'll give them more freedom in terms of crafting, and they can still do. It's still going to be a pretty tight system, but they're trying to set up like a tiered system, whereas we have all ALS. They're trying to set up ALS, BLS.
Right. Okay. Which may end up working out well, as we're seeing in other cities. So it's good. When is this happening though? When is the transition to the city government happening?
It started last year, and it's just gradually like the state's funding, 50% of it, and then 25% of it, and then they're on their own. So
okay, cool. And then unfortunately, neither you nor Sean can make it over here this year, right? So it'll be sad to be without you.
Yeah, I'm kind of bummed, but too much going on.
All right, but we will see you next year. I'm confident, so which is great. Yeah. All right.
Thank you.
Well, listen, no, thank you. Rob, anything else on the IDN from your end, or anything else to report from Washington, D.C.?
No, but I'll just comment. I think your comment about a lot of the stuff in the data set that John provided as being intuitive, it's starting all to make sense, right?
Yeah. And
it's not complicated.
Like early on, I remember at day one on February 20th, when everybody was saying it was droplets or 6 feet or, whatever. I mean, it was intuitive is that it's like radiation. The closer you are and the longer you're there, and also the less barrier you have, it's kind of like radiation. The more your risk of getting it is there. And then of course, viral loads are the big ones. If you're in a bar where people are just shouting above their heads or in a choir, that kind of thing. So
Sure.
yeah, in retrospect, Clayton was asking John for the graphic you show, if you could send a link or somehow distribute it via email. Anything else happening, by the way, in Washington that we should know about, or anything else of note? So
No, nothing of note. We're still at medium level
All right.
of community transmission.
So I will get into because of time restrictions for Chris Colwell, that I'm going to make a rapid transition over him. As I alluded to earlier in the talk, is that Chris wanted to make some commentary. Yeah, we're not an organization that takes positions. We're just who we are, getting the data, talking to each other. And I like to set that up as such here, is that when I'm putting Chris on, he's just one of us. We know that this goes out publicly, but it's one of us commenting on what's happened there. And I'm going to ask Peter also to comment, because both, Chris, for example, was involved with Columbine, but Peter was also right there in the middle of the Parkland shooting. And so I think it's just a good time to get off what you are feeling about it. So Chris, you did ask if you could talk about it today. So is that, at least we could do it in more detail at Eagle Creek, but tell us a little bit more about what you're feeling today.
Yeah, thanks, Paul. First of all, hey, everybody. And I personally have been struggling a little more than the others. So some of you may know I was a physician at the scene at Columbine, and then and treated patients from the Aurora Theater shooting, along with all of the regular shooting events that we have all dealt with on a regular basis throughout our careers. And I got to say, in 1999, it was kind of a lonely spot. There hadn't been that many of us that had been involved in these situations, either at scenes or in the hospital with EMS. And it's not so lonely anymore, and that's a pretty sad statement to make.
Yeah.
I think when I look through this group and the various experiences that they have had, the cumulative experience we've had is powerful. And where it became most clear to me is, as some of you may know, I know we try to stay away from politics, but I'm going to jump into it anyway. We had a federal assault weapons ban in 1999 when Columbine happened. There was a federal assault weapons ban that expired in 2004. Many of you know that. We are now down to 7 states and the District of Columbia that have assault weapons bans. All are being challenged, and even in California, a federal judge has weighed in that's going to try to reverse it. So we're looking at a time where we might not have any assault weapons bans. 23 years after Columbine showed us how devastating the issues are when you put a weapon like that in the hands of an impulsive teenage boy's hands. And so what they asked me to testify for the assault weapons ban challenge. And what really impactful for me was how much the voice that we have, and particularly our experiences with not only ourselves, but the people that we work with that have had to face these types of things, how powerful that voice is, even to a federal judge who is very conservative. And it just occurs to me that we as a group have some ways to advocate that I think I would like to at least explore how we might dive into in several areas. I gun reform is a big one, but if you want to stay away from gun reform and for some reason that doesn't sit well with you, we have violence intervention programs that are moving into the pre-hospital arena now and really effective in identifying potential opportunities there that I think are just scratching the surface. And although that's probably not going to hit the school shooters as much, it's going to hit the victims that we're seeing on a daily basis, I think, in a very substantial way. And we've got some good data to back that. And then finally, mental health reform and some issues going on in the country on that. And it seems to me that our group, wanting to stay away from political issues, could still weigh in in a couple of very impactful ways based purely on our experience in any of those three areas. So I want to throw it out there as a potential to delve into something. I realize that we've got an international group here and that what we're talking about is almost uniquely an American United States catastrophe and embarrassment. So I ask for your patience for those of you in other countries who are looking at us like, the hell is wrong with you? I get it, and you're right. But I also think we could use your help in terms of how different things are in other countries and how much more successful that is. So I was a therapy session. So thank you, Paul, for allowing me to inconvenience this group in that way. But I've really been struggling. These last two in Buffalo and in Texas have hit me a little harder than the previous 98, 99 events that looked very similar. And it's one where I think we have an opportunity to do something we haven't been doing. Paul, you're on mute.
Paul, you're on mute.
Chris, I am so with you on these issues, and I think there's a fundamental problem in the way that the government is operating, and it's a problem on both sides of the aisles. It really doesn't matter. They're not taking actions on both sides of the aisles. They're voicing a bunch of words and doing nothing. And I think that we just can't go on with, as usual.
Well, let me
Thoughts
ask
and prayers are not enough. They're just not enough.
They're worthless, mean nothing. They don't change the situation. And in a sense, by them doing nothing, to me, that's very much aiding and abetting. They know that their lack of action, just as if I know that my neighbor is building a pipe bomb and I don't say anything, I can be charged with aiding and abetting. They know they're facilitating these. They're aiding and abetting all of these crimes, all of these murders of these beautiful little children and people.
So Peter, let me move over to Peter. Peter, you were right there at Parkland, where not only it was your neighborhood. Your wife was one of the first attendees at that school. She was a class president. There's all those connections that those families that were there, and there you were on the scene having to take care of them. So first of all, I think that I don't know if anybody saw Peter, but he was on 60 Minutes Sunday night. It was so effective. Peter, I was going to try to play that today. The time is like moving along, but at Eagle Creek, can you get me a copy of that presentation that you did? I think it's really, I don't know, or I don't know if you even have it right now, but I think it would be extraordinarily moving, because you should see what he talks about, especially the next day when, having heard about this, his own son says, should I go to school? Being frightened about going to school, etc. And it was a powerful piece that 60 Minutes ran, and in all this, I think I want to take time to run it at the at Eagle Creek, at least, if you would mind, Peter. Would that be okay?
Yeah, no, I would appreciate that. It's interesting that, just so everyone understands on the call, that they filmed that in 2018 after Parkland, and I got a call about a week ago from the producer of 60 Minutes, and she says, Pete, we're running the episode again for a fourth time. And this time around, I probably got 100 texts, phone calls from people who thought that it was just filmed recently. But the sad part of it is that story is playing over and over and over again, and nothing has changed in the last 4 years. But I do want to mention, and just going back to Chris and Paul, what you've done is that, Chris and Paul and others on this call, anytime a shooting happens, they always check in with me. And I can't tell you how important that has been for me. I've seen a lot of death, as many of you have in your career. And that's never really kind of truly affected me. But Parkland, man, it totally screwed me up. I mean, I needed therapy. I needed help, right? And, I'm not someone who comes home and talks to my wife about this stuff. I don't tell the kids about anything. And so the fact that I have people like Chris, Ron Roth would reach out to me, Miramontes, Paul, obviously, I speak to quite a bit. So just having this group as people that kind of know what it's like, have been there before. And my heart goes out to Mark Escott and others who are on at the Uvalde scene. Chris told me when it first happened, he says, Pete, it never gets better. And every year on the anniversary, you're going to feel it. And he was right. And, and it's just, it hurts me. Like I didn't watch the episode on 60 Minutes last night because I couldn't on Sunday night because I didn't want to watch it. I can't see that anymore, unfortunately. So there you have it.
Do you mind though if we share it with the group?
Sure.
Yeah.
Absolutely,
I think see it because it's powerful because they talk about what these automatic weapons did. And unfortunately, we're hearing gruesome information about how their faces are blown off or whatever it may be, and they couldn't even identify kits, that kind of thing. And so any event, thanks. The other thing is that I don't know, a lot of people, Peter gave, I do want to say something here. Peter gives credit to, for example, Sandy Hook in terms of getting people on the streets with this Stop the Bleed programs and so on. And we do all know that, but I have to say, Peter and his fire chief here in Davie, Florida, actually started such a program long before that. And it is kind of interesting that you had to go face it yourself after always being prepared for such things. In fact, Peter and I were actually literally teaching the mayors and city commissioners for 5 cities in Northwest Broward County, including Parkland and Coral Springs, the responding fire department, only 4 or 5 days earlier, talking about that getting Stop the Bleed kits out there, and just it's unfathomable. But the problem is that the guns have already done much of the damage ahead of time, and in this case, it was just unbelievable. So, anyways, thank you. I'm sorry to have brought this up, Peter, but I just thought because it brings back bad memories. But Chris wanted to share it with the group as well. So,
yeah, the other thing I'll mention, and these are the things that I kind of like reflect upon that actually helped me out of the hole, is that, what a lot of people don't recognize about Parkland is that there were 34 people who were shot, 34.
Right.
And 17 of those, we had tourniquets and chest seals on, not by my paramedics, but by the police officers and the SWAT medics who went in there that we had trained on doing that, thanks to you, Paul. And, all 17 of those people who were, pretty badly wounded, they all are living and they're perfectly normal today. So, I'm very happy that after the Parkland report came out, that the score that the EMS got was really, superb. And so thankfully I can at least say to myself that we did some good that day, even after the horrific events that occurred. And I hope that other people are doing the same in their communities as far as training and police response as well.
Well, I think if you don't mind, let's set aside some time at Eagle Creek to actually have a further discussion on this, get input from everybody, maybe give them suggestions where they can help out. I will show the 60 Minutes, piece if you don't mind, and then get input for the group, and maybe even make a presentation from Thomas Jefferson as well. So as we talked about, right? So, Chris, anything else you want to say before I move on to other topics?
No, I just think, we have got some really, really powerful stories in this group, and we need to use them. People have talked now for a long time about the will of this country has not been moved. And I do sense that they are ready, and I think it's going to need a push, and I think this group is primed to do it. What you described with Peter, my experiences and several others in this group directly, and many others in this group indirectly with people they work with, have a really powerful story. And together, I think we have a powerful enough story to make some movement.
All right, so I think that's reasonable, and just to say you just present the data as usual, okay? Not an opinion. Here's the data, and here's the information or our experience. It doesn't have to be what we always would call objective data. It could be subjective data as well. So I think thank you for leading that and remind us that we really have to have some social obligation as well. So thank you so much. And just, we're with you, Chris, you know that, and so on. Hey, Chris, I just want to say on your name here, it says Chris Colwell, he, his, and then there's an EI. Does that stand for extraordinarily intelligent? What is that?
Yes. It does. And I have many other abbreviations to describe me, none of them presentable for this group. Actually, that's supposed to be an ELL. So
Yeah.
he, his, L.
Yeah, exactly right. So that was great. So, all right. Hey, Eileen, anything else before, because I got to get some other topics on here today.
No, I just wanted to point out what I put in the chat, which is if you're going to hold the session, let's try and forcibly make it productive by having everybody, having a sheet everybody fills out and thinks up 3 ideas, and then maybe discuss them. That's all.
Why don't everybody think about it right now who are on the call, and then that'll give us a good head start on this as well. So, all right. So thank you. Good suggestion. All right. So let's say, John, do you want to first of all, I'll have Peter come on and make an introduction on the next topic about intraosseous. I was hoping Miramontes would get on with us, but I don't see him. And then maybe John, if you don't mind doing a quick introduction of Sun-Hee, okay?
Yeah, I'd like to, I was a little bit surprised, but Sun-Hee sent me an email this morning. Sun-Hee Chun, she is a assistant professor of pediatrics at Oregon Health and Sciences University. But the reason she's in here is that she's also an associate EMS medical director for Multnomah County. So she's my pediatric go-to person for all things in pediatrics, and I've learned a lot from Peter. So I got a counterpart on the West Coast, Peter, as well. So you got some competition, Peter. Sun-Hee's been very interested in resuscitation in children here as well. And without much ado, back to you, Paul and Sun-Hee.
Yeah. Peter, why don't you do the introduction, see where we're going with this and what you want to discuss? Because I do want to get a couple other people to give reports on whether they be Mike Levy or Doug Kupas and some others that I want to hear from, Chris Suver, et cetera. But let's go ahead and move into this realm just to people there.
Absolutely. All right. Thank you. Thanks, John. And thanks, Sun-Hee, for coming on. I was fortunate to be connected with Sun-Hee. She's up obviously in Portland and was interested in the distal femoral placement of the IO in kids. And there is really zero data out there. If you look, we've looked. There's no studies on pediatric distal femoral IO. Dave Miramontes came out with his paper just very recently, which we discussed on this webinar probably a few months ago, where he actually looked at 2,000 cases of IO placement in San Antonio. And he showed that all the paramedics, after they were allowed, they kind of all moved to the distal femur. So we're trying to do the same thing for pediatrics, and Sun-Hee is leading the charge with getting an IRB together. So I won't steal her thunder. So I'll pass it over to you, Sun-Hee, to discuss that topic.
Peter, before we go, we've been allowing the distal femur IO in pediatrics for the last 2 years. And last year, about 50% of our pediatric defined as less than 18 have been distal femur IOs. Also, our data on adults with this humeral, we have a double ROSC rate with the humeral IO. So the site does make a little bit difference. Sun-Hee, go ahead.
Yeah, John, before she goes on, let me ask you this. What percentage had a distal femur?
50%. We only have about 20 to 22 cardiac arrest resuscitation requiring IO. And so about 5 to 10 had a distal femur IO.
Okay, got it. And then, and of course, I think we're not going to the humeral side because, especially in kids, let's say under 10 or 11, because of the growth plates and all those kinds of issues. But also, what I am thinking that there are the bone sizes though also can make a difference, and especially if they're under 2 years of age, they can be very similar. And then, so I was wondering if we do, I'm just going to throw this in, if we do studies, maybe we do stratifications according to that. And I don't know if we've done that already. Okay. So,
yep.
All right. Well, with that, Sun-Hee, I think you got a general idea of who the people are on the phone today, right? and so on. And if you'd like, I'm going to try to see if I can either have you personally come down to the Eagle Creek and make a more formal presentation to a larger group. But the bottom line for everybody else is that we're going to see if we can recruit people from around the country to maybe participate in the study that's already IRB'd out of Portland. So with that, that's where we're going with this. Just so you know, why don't you present what you're thinking? Okay, if you don't mind. Thank you.
Sure. Yeah. Thank you for the introduction. My name is Sunhee Chung. This is my second year of being a faculty. So I recently graduated from PEM Pediatric AM Fellowship. I am a pediatrician by train. I got interested in this topic because there's a lot of frustration clinically with IO placement. There's not a great strategy in kids where to go size wise, according to the weight or the age, and then where to go. So distal tibia, proximal tibia, distal fem. And recently we're learning anecdotally that femoral IOs are probably going to be a better site compared to the traditional proximal tibia, but we don't really have a great data on that. So I do want to look at retrospectively just kind of review the run charts and see what they show. So the primary outcome for me right now, that I got a IRB approval for, is how many kids are getting IOs in femoral versus tibia, and then what is the success rate, what is the dislodgement rate, and then what is the fluid amount that is infused. This is going to be a little tricky because the indications may be different in different EMS agencies, so we're going to have to accommodate that as well. But if we can get more, just because we don't have a lot of IOs in kids in pre-hospital setting in just one agency, I was trying to get as many participants as possible so we can get a better number. It would be more of a descriptive study at this point.
Okay, got it. So I think you're going to have a lot of people who are going to want to participate in this. And then, so I don't know, we could try to get offline. We could talk about this on another session because I got to move on to some other topics. But also, if you can find a way to get down there, we could talk to John about it, get you down to the Eagle Creek. Maybe we could do a presentation and more formal. Because my answer to this, my question, big question, not answer, question to this is largely going to be, what is how are you going to define the endpoint? Is it complications of that versus the other? Is it failure? Is it dislodgements? And how do we identify all those issues? And I think those are going to be the important thing at this point in time. So that's my point. Anybody else have any other comments before we move on? That's a good sign, by the way. I want you to know. Okay, said he. Okay. It's not that they're all asleep. They're all paying attention. Believe me.
I appreciate this opportunity. Thank you so much.
Hey, does anybody have something for Doug Kupas? Because he was asking, does anybody have a distal femur diagram or teaching tool for EMS clinicians? That's all. So,
yeah, Doug, I can send you something that I stole from Dave Miramontes. Dave had a video that him and Scotty Bolater did out in Texas, and I did a short little segment on that. I'll send you the video here in a second. But Dave has really done all that, and the majority of their IOs in adults are now on our distal femur. But Paul, I wanted to mention one more thing.
Yes.
That I'm wondering if, as part of the study, is it worth doing a survey of paramedics who have the option of tibia versus femur, to actually ask them what is their preference and why. And I think kind of understanding why they do things and why they like to do things, we'll probably get some insight there too.
Either we can assign that to Sunhee or anybody else who wants to take a crack to design a survey for us that we could set out via Stein or wherever that we usually do. Okay.
Yep. Sunhee, before we go, I can give you anecdotal training information from our peds. We just finished our session 2 months ago. There are two real reasons. Number one, anatomy for the very, very young in the newborn or less than 8 weeks old. It's much easier to obviously find the femur. The second most important reason is that we had a lot of dislodgements with the proximal tibial. And our crews, when they get it in, don't have any trouble. They have a hell of a time keeping the tibial IO and small kids in without dislodgement. So that's why when we asked our crew members why they like the distal IO, they said, well, first of all, it's easier for me to find it. All I have to remember is to put it on the medial side. The second one is that it doesn't come out. And the tube tamer doesn't really, tube holder that EasyIO has doesn't really work on small kids. I don't know what Sun He feels about that.
The size guidance in the EasyIO is a little bit unclear, I guess. And I think we definitely need a better strategy on that as well.
The reason for the sizing inaccuracy is because when they went for FDA approval, they went weight-based.
Mm-hmm.
And so the needle says something like 3 to 39 kilos.
Mm-hmm.
When it really should be based on when you put the needle and you touch the bone, do you see a black hash mark? They refuse to go back to the FDA, open a can of worms, and then have to struggle through that. So they're just going to leave it alone. And then we have to train appropriately on our end. So unfortunately, it is what it is, and it's not going to change.
Okay. Well, all right. So I think we're going, but this is I think it's a good discussion, because I've maybe taken it for granted. That's what I do, but we should basically have better data and prove that we're doing the right thing here. And I like the idea, as I sort of brought up early on, that we do stratify according to some size element there some way, somehow, as we look at this. So, all right. Anybody else have any comments to make before I move on to the others? So let me go over to Doug Kupas then. And Doug, anything reported either out of the state of Pennsylvania the Commonwealth of Pennsylvania, or anything from NAEMT or others associations that you work with, such as NAEMSO?
Hi, Paul. Yeah, a couple things on the NAEMT front. First of all, we're circulating some and disseminating some information on monkeypox via the NETEC information that they put out there. One of the few that I've seen put out some specific to EMS information. So we have been disseminating that out. Obviously, early, and many places have not been touched by this yet, but a lot of people looking for some education on it. We thought that was a pretty good site with some good information. The summer meeting for the board will be in July, at the end of July, in conjunction with the EMS Memorial in Washington, D.C. And we'll be participating in the memorial, and NAEMT is sponsoring some of the things, like I think a breakfast. So that's going on. The educational front is continuing to move, and I think has picked up quite a bit as things have, by perception of people, eased after COVID, even though we know it's not totally eased. But that's caused the educational programs to skyrocket. The new safety, the third edition of the safety course and book is essentially done and at the printers and should be out very shortly. Just was happy to see that over this past weekend, Dave Page and some others started a program in Morocco to open a training center in Morocco with PHTLS. So lots of cool stuff going on with education internationally, and also with our courses being updated in things like the safety course. That's pretty much the NAEMT news. I think, on the Pennsylvania side, realizing that I'm not, speaking in my state capacity at this meeting with the state, but, much of the same as to what people have been saying. We're watching, we've got sort of a pocket in the northeast of the state, which matches the United States map, where there's this red zone of high risk in the northeast of the U.S., while in Pennsylvania the northeast has the higher risk areas on the map. But it certainly seems to be spreading, and more places having increased rate. And that's all I have, Paul.
All right.
Looking forward to seeing people at
you mentioned, and I told Pam she should come hang with us, by the way. So just so you know. All right.
Pam is coming. Pam and Bruce Evans, the president of NAMT, will be at Eagles.
Mhm.
And I'm looking forward to seeing everybody. I'm not going to be at Eagles Creek because of the Budstein meeting in Norway. So if travel goes really well, I'm going directly from there to arrive on Wednesday to come and see everybody at the gathering at Eagles.
Fantastic then. Okay, good. Well, thanks. Safe travels, etc. All right. So let's see who else. Mike, anything you want to report on from NAEMSP? Physicians?
Sure.
Sorry to catch you off guard.
Again?
Said sorry if I caught you off guard there, but that's what I always do anyways, right? So.
Just with regard, I sent a note to everybody, a little tweet I saw regarding contributors to campaigns, AMA, et cetera. I just want to point out there that NAEMSP also has a lobbying effort. And while we're not listed there, I can't exclude the possibility that we've made those contributions as well. I think one of the things that make this a very difficult subject is the fact that when organizations, medical organizations lobby for their best interest, it unfortunately has to be agnostic of the people they're playing with to some extent. And so I don't really know how that gets resolved, but I suspect that's one of the core problems we have overall, why we can't change anything in terms of these bigger issues. But leaving that aside, we finished the Government Relations Academy again with our lobbyist H&K in Washington, D.C. Unfortunately, wasn't able to attend that personally due to having to keep track of Paul Pepe in Scotland. But nonetheless, it was
Terrible
a very
indeed. Yeah. Okay.
I thought they were going to give you a new berth at this River Clyde or something like that. Did that happen or not? I didn't see
Not
the
yet. Not yet. Yeah. It has. There's so much government bureaucracy to get that done. So all right.
But nonetheless, people should probably put this on their things to do for the coming year. Again, in next May, we'll have another GRA, which I think really suits the physician members particularly well in terms of how to interact effectively with legislators. So more on that through the NMSP website and probably through the Eagles as well. Paul, I wanted to touch on the nurse practitioner posting that came out. I think Sandy was the first one to put that out. And it was basically a statement by the emergency nurse practitioners regarding their place in the EMS world. Overall, I applaud all of advanced providers who interact with us in EMS. And clearly that's a very, very important facet of everything we do. And so 100% embrace their place in EMS. Concern we have is regarding EMS medical direction and oversight provided by physicians. And that's the part that is causing a little bit of concern with regard to that document. If you look at the position statement that the NMSP published through our task force, it's explicit in the first line and thereafter that APPs are a vital partner in the overall scheme of EMS provision, but these systems are fundamentally and always led by EMS physician medical directors and medical oversight. And that's something, honestly, that's missing in that document, which we're going to have to address in some fashion. Since that horse has left the barn, I really don't think there's something to do with regard to their document. But I think that if people were to go back and look at the NAMSP document, I think that it would find that to be the one they need to endorse. And I think that's a way going forward that we need to try to address this with regard to being sure that systems quality and oversight resides with physicians. AAEM is on board with us on this as well. I've notified the EMS committee at ACEP on this period. We just provided another very successful Foundations of Medical Oversight course in Anchorage, Alaska. And just to make members aware that the FOMO course does exist through NAMSP now, something you provided through your state chapters with or without a national help. And we're also finishing the asynchronous course. Paul, that's kind of it in a nutshell. There's a number of other things, but clearly short on time. Just wanted to give a quick overview there. Thank you, sir. Thanks for everybody.
That's great. Yeah, because I had about 10 other people I wanted to get to. I may not be able to, but thank you so much for doing that quick run through. And by the way, in Florida here, Peter Antovides, I think, just got elected the president of the chapter here. So I don't know if you're aware of that, but we did that to punish him for many things that he's done over the last few years. So that's all. Anyways, I just wanted to make sure. Peter, next week, if you wouldn't mind, let's bring that up and also not only talk about the election, but the people who how it all went and the various people who were in the election. I'm just really happy to have you on board because you're a true leader here. So thank you.
Thanks, Paul. Appreciate it.
Let's go at least to Mick Malloy. There's a lot of people here I want to talk to, like Lakshmi and Rob Lowe and Ben Lawner and Ben Weston and Clayton and Crawford and Rob Dunn. But I promise I'll catch up with you guys next week. Chris Zuver, particularly, I wanted to talk to. But let's start with Mick Malloy in Ireland and see if there's anything to report from there. And if Chris, you could stay around, I'm going to try to at least hit you up, Chris Zuver. Okay.
So it's interesting to listen to all the updates from everybody else. So just for Glenn Aceda's information, we have temperatures in the 50s and there is no violence and no crowd control issues with that. There is a little bit of a water coming out of the sky issue, no sun at the moment. We currently have 2 cases of monkeypox. So I was extremely grateful for the chat last week and the updates from the various ID people on the call. Obviously, the journalists are trying to make a big deal out of this. We had our Irish Medical Organization annual meeting at the weekend, and all the public health docs ran away when the media arrived. So I got put in front of them to talk about monkeypox. So I was glad I had at least 5 sentences from this conversation we had last week.
Good.
It doesn't look like it's a big issue. One of them was a person who came off a cruise ship, and the other came from a music festival in the UK. So
Nick, can you tell us about their presentation specifically? How did they present? Did they present with a rash first or with a prodrome first?
The rash.
And it's a genital rash in your 2 cases first?
And trunk and genital.
Well, it doesn't usually go to the trunks until it's done genital, face, hand, palms and soles. But what was that different in your case?
I didn't see them all, so I'm only going on the reports we got on our little WhatsApp network from the various emergency departments. So yeah, it must have been an early genital thing, but it had spread by the time they'd come into the emergency departments. The big issue then was the person who was coming from the cruise ship. The general advice we got was people go home and isolate at home, but they don't have a home. So they ended up having to stay in that hospital. And we didn't do testing over the weekend, so they were in the hospital for 3 days waiting for testing.
Okay.
Did they say anything about pain? The pain of the lesions?
They didn't say. Well, I didn't have anything reported on that from our other ED colleagues. I can ask.
Okay. Good plan. Look into it. We'll get back next week then. Thanks for doing. Before I cut everybody out, because it is 1 o'clock here on the East Coast and 10 on the West. I do want to say hi to Chris Zuver because we're lucky to get him on today because he's always busy doing so many things. Chris, are we going to see you down in Fort Lauderdale?
Paul, yeah, thanks. I will be down. I'm looking forward to it.
Can't wait. You're doing such good things there with resuscitation centers. I want to report on that. So that's great. But go ahead, Chris.
So we're working through the resuscitation center process right now. We're moving slow but steady. I'd hope to start by now, but I think we're going to get our cards people on board.
Yeah.
And I imagine that both the giants in the neighborhood will fall when that happens.
Okay, good. And
we have the National Special Olympics here next week.
Which Olympics are there?
The USA National Games for the Special Olympics will be in Orlando next week.
Special, yeah. That's it. Yeah, you ought to talk to Ray. It'd be an interesting contrast. Ray Fowler ran those in Atlanta years ago. So that's kind of interesting. So that's good that you get to do that. Good for you. That's right.
And that's the big stuff. COVID here is, it's COVID.
Yeah, yeah.
We look at 20%, 21%, I think, 14-day positivity.
Yes. Yeah, yeah. What you remind me, were you directly involved or indirectly involved with the Pulse shooting nightclub? Because I think I was calling you that evening, if I remember correctly, right?
The other Chris was here then. I had not come back yet. So
Ah.
Hunter was here back then.
That's right. Okay, got it. Yeah.
I'm happy to say that I missed it.
Yeah. You were up in Wisconsin at the time. Yes. Okay, got it. Okay, got it. Yeah, I just wanted to see if there was any commentary. That's a sad thing. What time of year was that? I can't remember when Pulse happened.
It was June. It was
Yeah.
the beginning of June. And
I knew that was coming up. So sad stuff. All right. It's always these vulnerable populations that are hit, it's really awful. So, all right. Well, I think I better shut everybody off. There was a lot of other, unless anybody wants to pop in and say something before we get off, I just want to thank you all for being here, and to apologize for not getting to everybody today, but hopefully it was still a good discussion for you all, and gets us some head start to what we'll be doing in a couple of weeks. Anybody else have any other things they want to comment on before I get off? Okay, again, the CME.
Thanks, everyone.
CME is 15243, 15243, and then for the Seagulls, 15242. All right.
Thanks, Paul.
I'm gonna go do my cloud thing myself right now. See you later, everybody.
Okay, bye, everyone.
Welcome back, my friends, to the show that never ends next week. All right. Thanks a lot. Bye.